Hello, everyone. Welcome to our Bridging Gaps in HFpEF, HFmref Care, and we will be starting in another minute. On behalf of the American Heart Association, I would like to welcome you to today's Healthcare Professional Connection Forum titled Bridging Gaps in HFpEF, HFmref Care. This event is made possible through the American Heart Association's Implement EF Quality Improvement Initiative, which is a 3-year initiative supported by Bayer that is designed to improve heart failure with preserved ejection fraction and heart failure with mildly reduced ejection fraction in patient care by gaining insights on current unmet clinical needs and practice pathways with a focus on evidence and science-based therapies. We will have a number of educational events throughout the duration of this initiative and encourage you to visit the website at the link on the screen to learn more. We have convened a 40-site cohort of multidisciplinary hospital teams seen here. Before we begin, I would like to quickly review how to use this platform for today's event. If you experience any technical difficulties, most user issues can be resolved by refreshing your browser. If that doesn't work, please review the system requirements or contact the Zoom webinar helpline. To access live closed captions, please click on the closed caption button found on your screen. Throughout today's presentations, you will have the opportunity to submit text questions for the presenter in each session using the Q&A feature on your control panel. You may send in your questions at any time, and we will review the questions during our Q&A at the end of each session as time allows. Finally, this forum will be recorded and available on the Implement EF website within the coming weeks. PDFs of some presentations may be available on the Zoom Events platform on the Sessions page. Attendees will not be automatically moved from one session to the next in Zoom Events. To join each session, you will need to navigate back to the lobby and go to the Sessions tab to join the next session. We will also be posting direct join links to the next sessions in the chat to ease any transitions. I also wanted to take a moment to remind you that the recommendations and opinions presented by our guest speakers today may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute endorsement or instruction by the American Heart Association. The American Heart Association does not endorse any product or device. We now welcome you to our first session titled AI in Action, Enhancing HFpEF, HFmref Diagnosis Through Site-Based Monitoring. This session explores how artificial intelligence assists with diagnosis and management of heart failure with preserved ejection fraction and mildly reduced ejection fraction. By leveraging site-based monitoring, AI tools enable real-time, decentralized analysis of echocardiographic and clinical data, improving diagnostic accuracy and accelerating treatment decisions. Today's presenter is Dr. Ambarish Pande of the University of Texas Southwestern Medical Center in Dallas, Texas. Dr. Pande is an associate professor of cardiology and internal medicine at UT Southwestern. His clinical interests include the management of heart failure with preserved ejection fraction, and he is the medical director of the HFpEF program at UT Southwestern. Dr. Pande's full bio is available in the lobby. With that, I will turn it over to you, Dr. Pande.
Thank you so much, Nancy, and good morning, everyone. And thanks for joining us today to learn about how we can get better in taking care of our patients with heart failure with mildly reduced ejection fraction or heart failure with preserved ejection fraction. And AI has a big role to play in healthcare in general, and there is a lot of recent advancements in role of AI in diagnosis of heart failure with preserved ejection fraction. So on that note, I would be presenting today some exciting developments in this space and how we can leverage imaging and AI approaches to screen for and early HFpEF. So I'll start with focusing on a recently approved algorithm that uses echocardiographic data for early detection of FPEF. So automated echocardiographic detection of FPEF using AI has been of interest a lot, and one of the leading algorithms in that space has been the Ultromix AI HFpEF detection algorithm. So Ultromix AI HFpEF detection algorithm was developed and trained on apical four-chamber video clips of patients with HFpEF. This work was done at Mayo Clinic, and this model was demonstrated to have very high sensitivity in excess of 88% and specificity of around 82%. So really, really good performance and a very low non-diagnostic rate of 7.7%. And this is really important because a lot of the traditional echocardiographic approaches to identifying HFpEF have a high non-diagnostic rate, including the current guideline recommendations. This model has been developed and further validated across several external cohorts, including some of the recent work done by the Beth Israel group, published in Nature Communications, and also more work from Mayo Clinic group that was earlier published in this year. And so we took this model that was subsequently FDA cleared for use for diagnosis of patients with HFpEF and tried to see how we can leverage it in our health system, in our community, for early detection of HFpEF. Diagnostic performance of this model is good, but what was not known was whether this model can actually identify early HFpEF in those who don't have symptoms yet or who have very mild symptoms and only have subclinical HFpEF. So we evaluated the performance of the AI echo model to screen for patients with subclinical HFpEF across two cohort studies, the Dallas Heart and Mind study and the MESA study. Dallas Heart and Mind study is a cohort of community dwelling individuals who have echocardiographic data both at rest and exercise. And MESA study is also a community dwelling individual cohort with echocardiographic imaging and detailed evaluation for subclinical HFpEF. So let's talk about the Dallas Heart and Mind's early HFpEF screening study that we did. So we had available echocardiographic images. We had clinical data captured for study participants. We had labs and cardiac biomarkers, and then we had exercise tests through cardiopulmonary treadmill testing done in these participants. So we had an assessment of their peak exercise capacity available as well. So in this cohort, we had around 705 participants who were free of heart failure, who did not have downstream missingness in the early HFpEF characteristics, and who had available image quality that was good enough for getting the Ultromix AI HFpEF algorithm run. So these patients had available CPX testing data, exercise echo data, and Ultromix-based assessment of their echocardiographic phenotyping. So how did we define HFpEF? And this has been a big challenge in the community of HFpEF investigators. And early HFpEF is basically a composite of impairment in the diastolic function of particularly with exercise or at rest, and presence of impaired exercise capacity as assessed by maximal cardiopulmonary exercise testing. So participants who had a low VO2 peak, less than 80th percentile predicted for age and sex, and who had echocardiographic evidence with E by E prime greater than 14 at rest or with submax exercise were deemed to have early HFpEF. So this is our workflow. This is really relevant for anyone who wants to use echocardiographic AI algorithms, because there is a substantial amount of back-end work needed at the level of the PACS system and the EHR. So basically, we identified the echoes through the accession number, which was available for their imaging, through SQL query in their PACS system. And then the DICOMs were transferred to Ultromix via a secure VPN FTP server. And then the images were de-identified and they got a new unique ID assigned by Ultromix. And then we had image analysis was performed in the cloud by the Ultromix algorithm. And then the probability of having early HFpEF and categorical output of presence of HFpEF yes versus no was shared with us as part of the deliverable from the Ultromics team. So this is how the workflow looks like at the back end in detection of FPEF in the using the echo data. So the first step is, and it's really important to understand this because it gives you the context as well as the explainability for the AI algorithm output. So the first step is basically view classification. So identifying based on the input video what view we are looking at because we are interested in the four-chamber view to identify the HFpEF phenotype here. So convoluted neural network algorithms were applied for view classification. And next step was auto contouring, basically identifying the contour of the LV cavity so that you can track its movement with each cardiac cycle. And that was done also using convoluted neural network. And then each frame was extracted from the cardiac cycle, and supervised ML algorithms were used for cardiac cycle detection and frame extraction. So you can know what is the morphology and the contour at different phases of the cardiac cycle. And then ejection fraction and global longitudinal strain was quantified, and subsequently automated feature extraction and quantification of the outputs was done. And we had detection of the HFpEF algorithm, detection of the HFpEF phenotype based on the four-chamber view and the analysis of the four-chamber uh, LV contour and the movements with cardiac cycle. So let's look at some of our results regarding the performance of the model in detecting the HFpEF algorithm. So we saw the area under the receiver operating curve for early HFpEF detection based on the gold standard of impaired exercise capacity and elevated E by E prime at rest or exercise was pretty high at 0.86. These are the characteristics of the patients stratified by the AI HFpEF detected phenotype versus not having the AI HFpEF phenotype based on the Ultromics algorithm. As you can see, individuals who were noted to have AI HFpEF phenotype were older by at least a decade, were more commonly females, but this difference was not significant, were less commonly of self-reported Black race. They had higher burden of hypertension, diabetes, coronary artery disease. They had higher BMI and higher systolic blood pressure. So this kind of tracks with the traditional cardiovascular risk factors that predispose to development of FPEF. So this gives you some sort of internal validity that the phenotype that we are capturing does have the clinical traits and clinical characteristics that we usually associate with patients who have FPEF. Let's look at some of the echocardiographic characteristics among patients who were deemed to have HFpEF based on the AI algorithm versus who were excluded or not deemed to have HFpEF. So if you look at here, the E by E prime was substantially elevated at 13.6 among patients with AI HFpEF phenotype versus those who did not have the AI HFpEF phenotype. Exercise E by E prime was also elevated. Left atrial strain, reservoir strain was decreased, which right? Ejection fraction was not the LV mass index was significantly higher. LA volume, left atrial volume was also significantly higher, and exercise capacity was substantially reduced with the peak VO2 of 14.36 in those who were deemed to have HFpEF by the AI algorithm versus those who were deemed to be not having HFpEF. And then E by E prime, more than 14 at rest or exercise was present in 77 individuals. That corresponded to 73% of the patients who had AI HFpEF detected phenotype. In contrast, only 16% of those who were ruled out for HFpEF by the algorithm had this phenotype of increased E by E prime at rest or exercise. And the overall subclinical HFpEF phenotype was noted in 22% of the AI HFpEF detected individuals versus only 5.8% of those who were ruled out by the AI algorithm. So you can see that even the echocardiographic characteristics are kind of tracking with the AI HFpEF algorithm's phenotype, such that you see more diastolic dysfunction, you see more impairment in left atrial strain, more left ventricular hypertrophy, larger LA volume, impaired exercise capacity, things that you would expect and things that were considered to be pathognomic of having clinical HFpEF. So we also looked at the association between presence of the HFpEF phenotype based on the AI algorithm, so the AI HFpEF probability, and some of the key surrogate outcomes, including the early HFpEF phenotype that was defined based on impairment in exercise capacity and impairment in diastolic function. We saw that on a continuous scale, per 5% increase in AI HFpEF probability was associated with a 12% higher likelihood of having the early HFpEF phenotype. It was associated with more impairment in exercise duration, more impairment in exercise VO2, higher stress E by E prime, and higher likelihood of E by E prime more than 14 at exercise with a 20% greater probability there. Similar pattern of results were observed when we analyzed the AI HFpEF probability on a categorical scale as positive versus negative with a threshold of 50%. So a very high probability of having early HFpEF phenotype in those who were diagnostically positive for presence of HFpEF by the AI algorithm. Lower exercise duration, lower exercise capacity, higher stress E by E prime, and higher likelihood, very high likelihood of having E by E prime more than 14. Now, let's look at the other cohort. One cohort results are good, which is reassuring, but we wanted to go beyond just one cohort and look at whether this model performs well in the MESA early heart failure study, which is a distinct cohort from the Dallas Heart and Mind study. So MESA cohort is a long-standing community-based cohort study that has been going on since the early 90s. And the early heart failure study was a subset of a follow-up exam 6 participants, in which around 2,000 participants who did not have history of heart failure underwent detailed echocardiogram with rest as well as leg raise, also had 6-minute walk distance and KCCQ assessments done. And the early HFpEF in MESA was defined differently because we had different phenotypic workup available. So it was defined by presence of heart failure symptoms, which is basically assessed on the Kansas City Cardiomyopathy Questionnaire with a clinical overall less than 80 or less than 60th percentile predicted by age and sex, and either elevated NT-proBNP more than 250 or elevated filling pressures at rest with E by E prime more than 15 or E by E prime more than 10 and LA volume index more than 28. Also, if there was impaired LA strain during physiological stressor with passive leg raise, it was considered to be one of the signs of early HFpEF. So basically, impairment in functional status and quality of life, and one of the biomarkers by echo or blood-based biomarker that would be suggestive of diastolic dysfunction. So in this model, the AUROC for early HFpEF detection was lower. It was 0.63, but still moderate or acceptable. And again, when we look at the characteristics of patients who were deemed to have HFpEF by the AI algorithm versus those who were excluded or ruled out, you see the same pattern of older age, more commonly women, no difference in race, but higher burden of cardiovascular risk factors, including hypertension, diabetes, and CAD, suggesting that there is same pattern of same pattern of increased burden of cardiometabolic risk factors in these participants. And in terms of echocardiographic statistics, we also saw the same pattern where individuals who were deemed to have the AI HFpEF phenotype by the algorithm had higher E by E prime, suggestive of more diastolic dysfunction, less negative global longitudinal strains, suggesting more impairment in LV contractility, lower LA reservoir strain, no biologically meaningful difference in LV ejection fraction, but higher LV mass and higher LA volume index. And again, when we look at the comparison of the early HFpEF or early heart failure phenotype across the two groups, it was present. So early HFpEF phenotype was not very different between these groups, but you did see slightly lower KCCQ and slightly greater change in LA reservoir strain with exercise in these with the passive leg raise in these participants. And when we look at the association of the AI HFpEF phenotype with presence of early heart failure phenotype, you see that both on a continuous scale, higher probability of having HFpEF by the AI algorithm was associated with higher probability of having early heart failure phenotype, was associated with lower 6-minute walk, lower KCCQ, and a trend towards lower LA reservoir strain with passive leg raise. And same pattern of associations was observed in categorical classification, comparing diagnostic positive to diagnostic negative groups for these outcomes of early heart failure phenotype. So based on these two studies, we concluded that a higher probability of HFpEF by AI algorithm was associated with higher odds of having early HFpEF phenotype and greater abnormalities in diastolic function, lower exercise capacity, and impaired quality of life. And this these findings are really, I think, meaningful because it tells us that we have a tool now that can detect HFpEF at an early stage, and it further needs to be evaluated in future trials to demonstrate whether such a screening tool can identify patients with early HFpEF in our health system and can help with initiation of guideline-directed medical therapy early and prevent progression to overt HFpEF or prevent progression to heart failure hospitalizations. So based on these findings, we were really encouraged, and we took the next step of uh, of basically understanding whether the we can use this technology, we can use this tool in our health system and implement it to early diagnose to aid diagnosis of HEF. Started with looking at echocardiographic database in our health system, and we identified around 9,406 patients who went under a clinical echocardiographic examination but did not have any structural heart disease. And these structural heart disease parameters that we looked at were basically impairment in LV function, very high LV mass, or increased LA volume, or increased tricuspid regurgitation velocity. So we excluded patients who have resting echo abnormalities. And we basically had 7,385 echoes undergo Ultromix HFpEF assessment. And then the AI algorithm detected as early HFpEF phenotype in around 1,728 participants, while around 5,657 participants were deemed to not have early HFpEF phenotype. And all these patients, the 7,385 patients, had some risk factors like diabetes, hypertension, obesity, or CKD. So they had two of the four risk factors present. And so we were enriching it for those with cardiometabolic risk factors. And we basically looked at whether AI HFpEF algorithm can detect those who are at increased risk of progressing and developing HFpEF on follow-up. So implementing it in our health system was also required a lot of close coordination with the informatics team. So we identified the existing echoes in the packs. We secured DICOM transfer for Ultromix analysis through secure VPN and network. The core lab at Ultromix analyzed the image quality and confirmed that it was adequate for assessments. And then the HFpEF algorithm analysis was performed, and the results were shared with our study team. So let's see how did we do in this real world health system data analysis using the algorithm. So around 1,728 participants were detected with FPEF based on the AI algorithm versus 5,657 who were deemed to be without early FPEF phenotype. Again, we see the same pattern of older age individuals, more commonly female participants, more commonly those with higher burden of traditional cardiovascular risk factors like hypertension, diabetes, CKD, and higher BMI in patients who had the AI HFpEF phenotype versus those who did not have the phenotype. In terms of echocardiographic characteristics, we see the same pattern of results where we see no difference in LV ejection fraction, but higher LV mass and higher LA volume in those with AI HFpEF phenotype. Let's look at the FPEF model with incident FPEF development and follow-up. So all these patients had an echo and then they had subsequent EHR level follow-up. And then the graph on your left shows basically the cumulative incidence curve for incident FPEF development among those who did not have Ultromix AI algorithm identified HFpEF, which are shown by the blue line, and those who did have the AI HFpEF phenotype shown by the yellow line. And you can see a clear separation of the two curves that happens within first, I think it's like 6 months, I say. Yeah, or first 1 year, because this is 500 days, so this is around like 250 days probably. So within a year or after a year, you see a very nice separation, and individuals who did not have Ultraomics detected AI HFpEF phenotype had a very low probability of developing HFpEF on follow-up. And you can see the adjusted hazard ratio here was 2.23 with a confidence interval that was very, very significant. And on the right side, we show the continuous AI HFpEF probability on x-axis and hazard ratio for clinical HFpEF on y-axis. And you see a very strong monotonic linear relationship between increasing AI HFpEF probability and higher risk of developing clinical incident HFpEF on follow-up. Both these analyses demonstrate the value of the AI HFpEF phenotype to identify individuals who are going to progress and develop HFpEF on follow-up in the near future. So this is all the data we have. And based on these data, what we have done is we have leveraged the algorithm's ability to identify the patients who have AI detected HFpEF and created a referral pathway where these patients are or the PCPs for these patients are contacted by our team, and they are requested for, and they're provided the information. They're told that your patient had a recent echo done in the last 6 months, and they may have signs and or evidence of early HFpEF, and may benefit from evaluation in the HFpEF program and initiation on evidence-based therapies. A lot of the PCPs are willing to send their patients for further evaluation to us, and this pipeline has helped us identify HFpEF at an early stage and get them initiated on evidence-based therapies sooner. So I'm happy to take questions and discuss more. I think I would like this to be a very uh, conversational session where we can address questions, practical aspects of implementing these algorithms in our health system, but also any questions regarding the performance of these models and how they can inform future care of these patients.
Thank you so much for sharing your knowledge and models from UT Southwestern Medical Center, Dr. Pandey. There are a few questions for you. The first
Excellent.
question is, if a hospital is interested in using this novel AI technology, what is the best way to implement this into practice?
Yeah, so I think there are two approaches you can take with this AI technology. So this AI HFpEF model is FDA cleared, so you can use it and you can build for it. And there's a lot of resources available through Ultromics on how to integrate in your clinical practice for patient level guidance in identifying HFpEF. And you can do it for inpatient or outpatient setting both. The model that we have used is more of a population health approach, where we have used it asynchronously with patient care and used existing echocardiographic data, and have taken an opportunistic approach where we have analyzed the echocardiographic images of patients who are available in our health system to identify individuals who may be at risk of developing future HFpEF by identifying the early cardiac phenotype that this model detects. And then that has helped us bring these patients to our clinic sooner and bring these patients to the right care platform sooner by getting them initiated on evidence-based therapies. So I think you can take either an individual diagnostic approach where you use this model for day-to-day care of patients when you see them in clinic or you see them in hospital, and use the algorithm to make aid in your diagnosis, or you can use it for a population health approach where you can run it across the health system's echocardiographic data and identify patients who may have subclinical HFpEF but not have had clinical signs and symptoms or not have been followed by cardiologists, and bring them to the treatment paradigm by identifying them early.
Thank you, Dr. Pandey. We have another question. What future innovations, such as wearables or remote sensors, do you think could further enhance AI's role?
Yeah, I think there is a lot of potential for AI to enhance our ability to identify patients who may be at increased risk of developing HFpEF or who may have subclinical HFpEF, but also to monitor how they do after they're diagnosed with the condition. And I think wearables like Aura Ring or Apple Watch or Fitbits can really give you a lot of good data on their day-to-day exercise capacity and day-to-day exercise behavior, and also their heart rate and their heart rate response to exercise activities, their sleep patterns. And as you know, patients with heart failure and HFpEF often have physiologic decompensations that lead to increased heart rate with exercise or with physical activity, reduced physical activity levels on a day-to-day basis, increased heart rate when patients lay flat. And all these patterns can be captured by a lot of these algorithms. And you can think that there could be algorithms that are created that use all these data to better identify early decompensation, to better identify patients whose cardiac whose substrate is not healthy enough to meet the demands and the requirements of activity, and those who have declined activity. Similarly, it can also inform monitoring to look at treatment benefits the same way, because you can see who benefits more in terms of their exercise capacity improvement, their resting heart rate, their blood pressure, and so forth.
Thank you again, Dr. Pandy, for the wonderful presentation, and thank you to our audience for your participation. We will be launching a poll to evaluate the effectiveness of this session, and we appreciate you taking the time to share your feedback. Coming up next at 10:50 Central Time, we have our next session, Spotlight on Admission, Models for Identifying HFpEF and HFrEF at Admission. Please return to the lobby to access
There
this
is another
session.
there is another question, Nancy. Another question that I see. This is hypertension patient plus type 2 diabetes, high PBBS or fasting blood glucose can get oral semaglutide since it's recently approved. How can it be used for prevention of HFpEF? I think it's a really important question. Is it okay if I answer this?
Yes, go ahead.
Excellent. So this is a really important question from Richard Piners. So I think weight loss strategies such as injectable semaglutides and tirzepatide and oral semaglutide are all really important therapies that have been shown to have a lot of promise in management of HFpEF. So as you may be aware, the STEP HFpEF trials and then the tirzepatide trial Summit, they all demonstrated that patients who were treated with these GLP-1 receptor agonists had significant improvement in their quality of life, significant improvement in performance on a 6-minute walk test. And so there is a lot of promise in their role in management of FPEF. With regards to prevention of FPEF, because obesity is such a causal, I think, factor in development of FPEF, and data from other trials like SELECT and FLOW have shown that it does reduce development of heart failure hospitalization, development of HFpEF, and a lot of patients who are obese, once they lose weight, their risk of developing heart failure goes down. So I think there is a lot of opportunity to leverage these therapies to reduce development of HFpEF. And one strategy that we envision is that you can identify early HFpEF phenotype, like by using AI algorithms like Alpromix. And then if they have obesity and diabetes, they can be a great, I think, candidate for therapies like GLP-1 receptor agonists. And I think in those patients with risk factors like hypertension, diabetes, who have early HFpEF phenotype, you can consider them for initiation on these GLP-1 RA receptor agonists sooner, and that can lead to improvement in their cardiac substrate, reduction in their pericardial fat that leads to diastolic dysfunction and reduce their risk of developing heart failure hospitalization. There's also a question by Susan Wayne about getting a summary of the echo parameters that could be forwarded to our echo lab to have added to our final echo report to help guide physicians when determining HEPA. So I think this is a great question. I think some of this should already be measured in your echo lab and reported in your echo report, Susan. And these parameters include E by E prime, left atrial volume, tricuspid regurgitation velocity, LV mass, and I think an E by A. And all these parameters can be inputted into like the guideline document for diastolic function to assess whether someone has diastolic dysfunction. And in the right context of patients with either volume overload or shortness of breath, presence of diastolic dysfunction can be suggested that they may have underlying symptoms like what we discussed about today are useful because they take away the cognitive load that you just described, which is remembering these echo parameters and including them in the reports, but rather the AI model does it for you and gives you an outcome of whether or not they have HFpEF, yes or no. And that is way more convenient with less cognitive load for providers to remember. And then it just facilitates the diagnosis better. And you don't have to do a lot of the guideline assessments, guideline recommended assessments. And when people have compared in clinical studies, AI algorithms like what we talked about is better in capturing true diastolic dysfunction than sometimes the guidelines even. All right. If there are no further questions, then thank you so much for joining. And you can always email me and I can get you more information related to the algorithm as well as related to any other implementation challenges that we encounter or that you may anticipate in using AI to aid in the early diagnosis of HFpEF.
Thank you again, Dr. Pandy, for the wonderful presentation. We appreciate your knowledge and expertise.
Thank you.
Yes, and our next session will begin at 10:50 Central Time, and the title of our next session is Spotlight on Admission Models for Identifying HFpEF and HFmrEF at Admission. So please return to the lobby to access this session using the menu at the top of the screen. And from the lobby, you can click on the Sessions tab first, and then click on the individual session to join. We have also posted a link to join directly in the chat. Thank you very much for attending today's session. We will see you shortly.
Thanks.